Vessel encasement in pancreatic NETs, borderline resectable disease. Hello. This evidence-based content is prepared by Saboor Khan, fellowship-trained consultant surgeon, and if you or someone you care about has been told that a pancreatic neuroendocrine tumor is touching major blood vessels, what surgeons call borderline resectable, I know that news can feel overwhelming. But today, we're going to break down exactly what this means, what your treatment options are, and, most importantly, why having a team of specialists matters more than ever. Pancreatic neuroendocrine tumors, or PanNETs, arise from hormone-producing cells in the pancreas. When these tumors grow near or touch major blood vessels like the superior mesenteric artery, the celiac axis, or the portal vein, they create what surgeons call a borderline resectable situation. This doesn't mean unresectable. It means the surgical team needs to carefully plan, potentially involving vascular reconstruction or treatments before surgery. Why does this matter personally to you? Because the degree of vessel involvement is the most important determinant of whether radical surgical resection is possible. Understanding this classification helps you and your care team make informed decisions. The classification system used for pancreatic NETs actually borrows from pancreatic ductal adenocarcinoma criteria. There are 3 categories. First, resectable means a normal tissue plane exists between the tumor and major arteries, the superior mesenteric artery, celiac axis, and common hepatic artery. Second, borderline resectable occurs when the tumor abuts these vessels, meaning it's touching them but not completely surrounding them. Third, locally advanced or unresectable disease exists when the tumor encases these arteries. But here's where it gets interesting. Involvement of the superior mesenteric vein or portal vein is handled differently. Vein contact alone isn't considered unresectable unless there's complete occlusion, meaning the vein is blocked. The involved segment needs to be manageable for reconstruction. Think of it like this. If a tree root is touching your water pipe, you can work around it. If the root has completely encircled and crushed the pipe, that's a different problem entirely. Preoperative assessment relies heavily on high-quality CT scans. CT scanning is the most accurate imaging procedure for studying vascular involvement in pancreatic malignancies. The imaging must precisely show whether vessels are abutted, touched, or encased. Infiltration of the superior mesenteric vessels or the common hepatic artery needs to be precisely investigated to define whether vascular resection is possible or whether patients should be excluded from upfront surgery. This isn't just academic. This imaging determines your entire treatment pathway. Here's something that might surprise you. Pancreatic surgery with vascular reconstruction in the presence of superior mesenteric vein abutment is safe and associated with acceptable outcomes. A large international study compared patients who underwent pancreaticoduodenectomy with portal vein resection versus standard procedures. The perioperative mortality was only 1%, though the complication rate was higher, about 48% versus 33% in the standard group. After careful matching analysis, overall survival and recurrence rates were not different between groups. The conclusion? Even extended resection, including vascular reconstruction, is safe with good long-term outcomes. However, and this is critical, data are still lacking to confirm the value of vascular reconstruction when the superior mesenteric artery or celiac axis is invaded. Pancreatic resection for NETs with this level of vascular involvement has rarely been described. Not all pancreatic NETs behave the same way. Selected patients with low-grade to intermediate, G1 to G2, neoplasms without distant metastatic disease may benefit from aggressive surgery, including vascular reconstruction. These findings indicate a more aggressive behavior when tumors invade major vessels or other organs. Multivisceral resection, removing the pancreas along with adjacent invaded organs, is associated with poorer survival compared with standard resection. Nevertheless, this approach should be contemplated only for carefully selected patients with favorable tumor biology. You can do the math. If your tumor is well differentiated with a low Ki-67 proliferation index, you're a better candidate for complex surgery than someone with a poorly differentiated high-grade tumor. Pancreatic NETs with superior mesenteric artery, celiac axis, or common hepatic artery encasement, complete surrounding, should be considered unresectable. The same applies to tumors with superior mesenteric vein occlusion. In contrast, tumors with abutment of these arteries or veins without segmental occlusion should be regarded as borderline resectable. For small intestinal NETs, a related condition, tumors with mesenteric deposits surrounding the mesenteric vessel root or extending retroperitoneally should be considered unresectable. Large mesenteric tumor deposits without vessel root involvement fall into the borderline resectable category. First, ensure you have high-quality, contrast-enhanced CT imaging of your pancreas with specific attention to vascular involvement. Ask your radiologist to describe the relationship between your tumor and the superior mesenteric artery, superior mesenteric vein, celiac axis, and portal vein. Are these vessels abutted, encased, or clear? Second, request that your case be presented at a multidisciplinary tumor board. Research in this area is ongoing, but one consistent finding is that complex pancreatic NET cases benefit from review by surgeons, medical oncologists, radiation oncologists, and radiologists together. Come prepared with these specific questions. Based on my imaging, is my tumor resectable, borderline resectable, or unresectable? If borderline resectable, am I a candidate for neoadjuvant therapy, treatment before surgery, to shrink the tumor away from vessels? What is my tumor grade, G1, G2, or G3, and how does that affect surgical decision-making? If vascular reconstruction is needed, what is your center's experience with this procedure for NETs? Advances in systemic therapies have opened perspectives for neoadjuvant treatments. Better local control or tumor shrinkage before surgery may convert borderline resectable tumors to resectable ones. Treatment options include peptide receptor radionuclide therapy, PRRT, which has shown promise in making unresectable primary tumors resectable in some studies. If you experience new onset jaundice, yellowing of skin or eyes, this may indicate progressive biliary obstruction requiring urgent intervention. Severe, unrelenting abdominal or back pain that doesn't respond to typical pain medications warrants immediate evaluation. Rapid weight loss exceeding 10 pounds in 2 weeks could signal disease progression. Most importantly, if your current treatment center doesn't have multidisciplinary tumor board capability or experience with vascular reconstruction for pancreatic NETs, seek a second opinion at a high-volume center. These complex cases demand expertise. Let me quickly recap. Borderline resectable pancreatic NETs involve vessel abutment, not complete encasement, and selected patients benefit from vascular reconstruction with acceptable outcomes. Your next step: obtain dedicated vascular imaging and ensure multidisciplinary review of your case. Remember, tumor grade and vessel involvement type determine your surgical candidacy. This information is for education. Always discuss your individual situation with your healthcare provider. I've outlined several reputable resources here which you may find valuable for further information on pancreatic neuroendocrine tumors and borderline resectable disease. The European Neuroendocrine Tumor Society provides comprehensive guidelines on surgical management, and the ENETS 2023 guidance papers address non-functioning pancreatic NETs specifically. Full links are in the description below.